Hello and welcome to JAMA Network Open Conversations. I'm Angel Desai, Associate Editor for JAMA Network Open. Today we are speaking with Dr. Simon Thomsen and Dr. Bodil Rasmussen about comparison of midline to peripherally inserted central catheters, a randomized clinical trial. Welcome to the both of you. To begin, can you please introduce yourselves?
Yeah, thank you very much. My name is Simon Thomsen, and I'm a consultant and anesthesiologist in the Department of Intensive Care in Aalborg and is head of our vascular access team.
And my name is Bodil Rasmussen. I'm a professor in anesthesiology and a consultant in the same department as Simon. And thank you very much for the invitation.
I want to begin just to say that I loved reading this study because I think this is a very practical question that comes up quite frequently in the hospital setting and outside the hospital setting as well. Can you start by discussing the background of the study?
The background of the study started back in 2007 or 8, where we introduced our peripheral inserted central catheters in our department, which was a new catheter at that time. And we used that over the years, but found that a new catheter, the midline catheter, may be a good alternative. But when I searched the evidence for the use of to us, this new catheter, very few have studied this catheter, and very few comparative studies hit to our standard of care at that time. So that's why we designed this randomized clinical trial starting in 2017, and we included the first patient a year later.
And you mentioned that the midline catheters used in this study belong to a new or newer generation. Can you speak a bit about what differentiates these midline catheters from prior iterations?
Actually, I don't know exactly because we've never tried the older versions, but I hear from older colleagues that the material especially gave some allergic reactions, and it was very difficult to put in these lines, especially because ultrasound was not a standard of care at that time. So difficult to place, and probably many more complications from this new generation, which are more like our other central catheters in material and in the way we put them in.
Great. So moving on, can you tell us a bit about the study design and outcomes of interest for this trial?
The study design is a randomized clinical trial, and we included all the eligible patients who have the needs of peripherally compatible infusates. And then we just put in the lines in a randomized fashion, one-to-one, and then we followed the patients until the end of treatment. So it was from the day we put the line in, it was just observable, and then we followed the patients in the clinical medical records and noted when the catheter was taken out and the reason why it was pulled out.
And these were all individuals who, for one indication or another, needed a more robust line than simply a peripheral intravenous line. Is that correct?
Yeah, because they had to have an expected need for more than 5 days, unless a peripheral line would be proper. But in some of the patients, peripheral line was not optional because they were what we call DIVA patients, as venous access patients. So they needed another line instead, but we randomized them to midline or in our study.
And what were your main results? What did you find?
We primarily looked at systemic infections, and we had only one in the PIC group. So inclusion, no difference between the catheters. According to major complications, which were a primary outcome. According to our secondary outcomes, there were more midline catheters were taken out before time because of what we call minor complications, primarily because of leaking from the catheter was the primary reason. So not dangerous complications, but there was a difference between the catheter groups according to minor complications.
Dr. Rasmussen, I want to make sure I give you an opportunity to speak as well. If there were anything that you wanted to add about any insights regarding the way the trial was conducted or the main findings.
I think it was interesting to be part of this clinical research question, because we have used the PICC line catheters for a long time, and there was a resistance in using the Midline catheters because the older colleagues have used the older ones and know that there was a lot of complication and it was difficult to put in the catheters. But when we started, I think it was started very excellent because it was skilled nurses. We decided to have a sterile condition when we put in the catheters and to use ultrasound. So it was in a modern way of inserting catheters. But I think that we expected the result different based on the observational studies. And it was a surprise to see only one systemic infection and only 2 DVTs. And what I think is important is that the minor complication is really minor complication. It's not dangerous for the patients. And also we saw that after 15 days, we saw the minor complications. It was not within the first 15 days. So if you have a need of an infusion for 5 to 15 days, you can use the MC catheters. And I think that's a very good result. It's a valuable result in the clinical setting because in many centers they use peripheral catheters and they have to change it every 3-4 day. So I think it's a very valuable clinical result.
Yeah, that was actually the finding I thought that was very striking related to the complications among the midline catheter group. And really that duration of catheter usage seemed to, it was a subgroup analysis, but there was sort of an association there. I thought that was interesting. And then I want to go back to something that you mentioned earlier, that the overall rate of catheter-associated bloodstream infections across the study was very low. And what would you attribute this to potentially at your institution? And how could this have affected the interpretation of your study?
As I mentioned, we have used the PICC since 2007. So the whole organization is trimmed to handle this catheter. And the way we handle the midline catheter is the same. So I think it reflects an organization which have high standards. And it's from the day we put in the line with a focus on sterility. And as well, during the use of the catheter, when we flush it, every time we have to use the catheter, and the hygiene procedures at the hospital and in a few patients at home. That's the explanation why we have this few infections.
And for clinicians who look at this study and who are considering whether to place a midline versus a peripherally inserted central catheter, how could the results from this study, recognizing its limitations, inform that decision process?
It can help them to look at the patients who need as their patients, because it's important to have an individualized approach when you choose the right catheter. I've seen studies where they use midlines for patients who need more than 20 days in average. And in that population, I will choose the PICC. But if you have only 5 to up to 15 days, I'll choose the midline catheter. So that depends on for how long they have to use it. And another thing I will point out, it's many studies have many occluded PICCs. We have only one occluded PICC line in our study, and that's as well an organization which used to handle this catheter. And if you introduce a PICC in another organization, you will probably experience more occluded catheters, especially in the beginning.
And I think the result shows the clinicians that you now have 2 catheters to choose among. And as Simon said, it depends on how long treatment you need. If you need a very long treatment, you should probably choose the PICC line. And if you have a shorter period of treatment, the midline. But it's important to emphasize that we put in anticoagulant in the PICC lines to avoid this clotting in the catheters. So you have to try to adopt the same algorithm that we have used in our studies to be able to obtain the same result as we have, because the number of complications is very lower. For example, compared to a randomized trial in a hospital, a university hospital just 100 kilometers from here because they have a much higher complication rate. And they do not use the sterile technique, and there's several different handling of the catheters compared to ours. So, but I think if you use the same technique, you have the same training of the personnel, you now have 2 catheters to choose among. And I think one of the most common remarks from our colleagues before we start was that they were afraid of the DVT using a midline, and we didn't saw any DVTs. So with the new catheter material, also we have diminished that risk. We have shown that this risk is lower.
That's great. Thank you so much. Before we wrap up, are there any final thoughts regarding this topic or anything perhaps we haven't covered?
I want to say something because as a researcher, I think it's very important that the clinicians working in the daily clinic, when they get curious and think, could we somehow prove or disprove if a new treatment is better than the one we use? I think the good clinical questions come from the clinicians in the daily practice, not from researchers never going into the practice. So I think it's important that we ask ourselves if there's anything that we just do because we have done that for many, many years, but raise the question, could we somehow do a clinical trial as this, which has been performed at the best standard to answer some of the many questions that we have in the clinical practice, but because there's so many things that we just do because we used to do them.
That's a great thought to end on. Thank you so much to Dr. Simon Thomsen and Dr. Bodil Rasmussen for speaking with me today about this very relevant topic. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.